What's up, everybody? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over flow volume loops. So, flow volume loops are always presented on a graph like this. We have volume in liters on the x-axis, and the volume is going to increase from right to left. And we also have flow on the y-axis in liters per second. And if you are below this middle line, we are talking about inspiration. And if we are above this middle line, we are talking about expiration. So for tidal breathing or passive respiration, let's say we're starting with inspiration, we would start about here and we would start to inspire volume, and our flow rate would increase as we generate that pressure difference between the alveoli and the mouth. And then as the alveoli equilibrate with the atmosphere and the alveolar pressure becomes zero again, our flow rate will start to decrease until flow is zero at the end of inspiration. And so we can see here that we've inspired approximately 500 milliliters, which is our tidal volume. And so as we are inspiring, our curve is going to be going this way as we are inspiring volume into the lungs. And the same thing is going to happen as we expire our tidal volume. The curve is going to be moving this way as we expire that 500 milliliters. All right, so a few questions for you. Can you remember what the primary muscle was involved in passive inspiration? That's right, it was the diaphragm. And can you remember what the primary mechanism was for passive expiration? That's right, it was passive elastic recoil of the lung tissue. So when we expire our tidal volume, we end about here. So what capacity does this volume of air represent? That's right, this is our functional residual capacity. Remember that the functional residual capacity is the amount of air left in the lungs after a tidal expiration, or it's the amount of air in the lungs at the start of a tidal inspiration. All right, so usually when we're discussing flow volume loops, we're not talking about passive respiration. Usually what we're doing is we're plotting forced inspiration and forced expiration. So let's plot our normal curve now. So here's our normal curve, and first we're going to start with inspiration. So we're going to start down here, and as we're inspiring, we're increasing the amount of air that has flowed into the lungs, and we're also increasing our flow rate. Then, as we keep inspiring, eventually we're reaching total lung capacity and our flow rate starts to decline. So again, during inspiration, our curve is moving this way as we are inspiring air, and we're ending at this point right here, which represents our total lung capacity. And the same thing goes for expiration. We move this way on the curve as we are expiring volume, and then we keep expiring until we can no longer expire anymore. So at this point right here, if we can't expire any more air, then what does this volume here represent? That's right, this volume here is the residual volume. Furthermore, notice how the slope of our initial portion of our expiration curve is much steeper than the slope of the initial portion of our inspiration curve. So this is basically saying that initially the flow rate increases more rapidly in expiration than in inspiration. And so during expiration, we have a faster initial airflow. And the reason for this is because, remember from our previous video, that at high lung volumes, like over here, that lung parenchyma is stretching open those airways. So we start expiration with very wide airways, and so there's very low airway resistance. So it's very easy for air to flow. Whereas down here at residual volume, our airways are very collapsed, and so there's high airway resistance, and therefore the air flow starts more slowly. And therefore, the reason expiration has a faster initial airflow is because the airways begin expanded. So with all that in mind, now let's talk about obstructive lung disease, and we'll add in our obstructive lung disease curve. And so the first thing you're going to notice is the graph is shifted to the left, and that's because in obstructive lung disease, these patients like to breathe at high lung volumes, and that's because at high lung volumes, the airway diameters are going to be stretched out, and so that's going to lower the amount of work that they need to do to overcome airway resistance, which is the main problem in obstructive lung conditions. The next thing that you're going to notice is that there is a bit of a scooped out portion to the second half of the expiration curve. This is very characteristic of obstructive lung disease curves. And the reason that we see this scooped expiration is because right here, the equal pressure point is moving close to the alveoli in a region that's not protected by cartilage. And as a result, we're going to see that the airways are going to collapse early in expiration. And so at this point right here, we're going to see early airway collapse. And so these patients are basically expiring through collapsed airways. And so the flow rate rapidly declines, and this is going to show up on the curve as a scooped portion of the curve. And lastly, we can see that in obstructive lung conditions, we have this massive residual volume compared to normal. And the reason for this is that if we just draw in our airways here, and let's say that the airways are very collapsed, then during expiration, as we have air in the alveoli and we try to expire it, maybe a tiny bit of air will be able to get through those collapsed airways, but the rest of the air is going to bounce back and be trapped within the alveoli. And all that air that's trapped within the alveoli is actually going to expand the alveoli and increase the residual volume. So in obstructive lung disease patients, they characteristically have increased residual volume. And recall that residual volume is a component piece of FRC, and it's also a component piece of the total lung capacity. So our FRC and our total lung capacity are going to increase as well. And this is all due to a phenomenon called air trapping. And so due to all of this air trapping, the lungs are said to be hyperinflated with air. It's very high yield to note that in obstructive lung diseases, the lungs are hyperinflated. And if we just look at the radiology on the bottom left of the screen here, this is a chest x-ray on the right of a normal patient. And on the left, we have a chest x-ray of a patient that has obstructive lung disease. And you can identify on chest x-ray some features of hyperinflation. So the first is that the lungs are very elongated and large compared to normal. And the second thing would be that on normal chest x-ray, we normally see these lung markings here, and that represents lung tissue, and that's because the amount of tissue present compared to the amount of air present is normal, whereas a lung that is hyperinflated, we see a lot of just this black space here, which just represents air, and that's because there's a lot more air compared to lung tissue than normal. So now we are going to be talking about restrictive lung disease. So we'll just add in our restrictive lung disease curve here. So again, the first thing you're going to notice is that the restrictive lung disease curve is shifted to the right, and that's because restrictive lung disease patients like to breathe at low lung volumes where they can minimize the work of overcoming elastic recoil. And also recall, we said in restrictive lung disease, it's very hard to expand the lungs, and so we're using a lot of musculature to keep the lungs open. We can see that on the curve here. The residual volume is represented by this very small space here. And again, because the residual volume in the lungs is low, the FRC and the total lung capacity are both going to be low. We can see that their total lung capacity is only about 4 liters compared to normal, which is about 6 liters over here. All right, so just to summarize here, obstructive lung disease patients breathe at very high lung volumes. They have early airway collapse, which causes them to have a scooped expiration curve. And due to that airway collapse, we get a lot of air trapping, which is going to increase their residual volume. And as a result, their FRC is going to be increased, and their total lung capacity is going to be increased. And in contrast, restrictive lung disease patients breathe at very low lung volumes. They have very little air trapping, and so they have a very decreased residual volume, and so they also have a very decreased FRC and a decreased total lung capacity. All right, and that's all we got for our video on flow volume loops.